x-ray. Now, when we get to semester 8, we're gonna circle around and find out all the different types of fractures that occur, but we're gonna say the same thing. Then I'll ask you where the center goes for the hand, okay? And the reason, they're not all this obvious, okay? If they're subtle, that's the reason for doing the 3 views, okay? All right. Abnormality where the arrow is?
Occipitalization,
Okay, teaching point, complications.
Arnold
Say it
Chiari,
again, Arnold Chiari. Okay, you need to know what that is. You need to know what it looks like on an MRI. At the foramen magnum, you've got cerebral tonsils where they shouldn't be.
and it's below this.
Okay? Now, this happens in the setting of, the reason they probably had the x-ray done was they were in a car accident and this is what we get. All right? Now, application, one of the students that graduated from here, she had an Arnold Chiari. They take out a section of your skull to create more space. She had nothing but it got infected. So osteomyelitis, she had nothing but problems her whole entire career here. All right, with suboccipital headaches, all kinds of issues, whatever. She's gonna have problems the rest of her life because it was not as successful, that doesn't matter. The surgery was probably successful, but that doesn't mean she won't have complications, okay? We just need to know that these are attachment sites. It's coming again. We've done pelvis exam. It's more for your information. It should go in your DigiVault. Trauma can be repetitive one-time trauma or repetitive. And if this gets disrupted, you get this funky looking abnormality in the AIIS. You just need to realize that muscles can be avulsed from their origin site, okay? This is common. You'll see this quite frequently, okay? We've done pelvis, so I'm just showing you something that's an application to what we've done in terms of lower our extremity positioning. This you see commonly, it's age related. So someone who is very active, a hurdler for example, when they get elderly, this ileocecal tuberosity can look really irregular, but it's bilateral. It's not a tumor. Tumors don't happen bilaterally. It's simply age-related change, okay? So again, another piece for your digital vault more than anything else. Observation, normal, not normal. Surgery. What kind of surgery, or describe the surgery? Fusion, okay. So the strongest point is the pedicle. The observation I wanted you to make is, these are what?
Spinous processes,
What's missing here?
spinous processes.
So they did either a laminectomy first, okay, and then a wider laminectomy, you get access to the disc, okay. I don't have the lateral, but usually if you see surgical intervention, that's to hold the disc in place, okay. So my argument is, you know they had surgery, you see the scar, all right? You can't use this as a contact point when you're doing your flexion distraction. There's no spinous process, it's been removed.
Right.
Not every surgical intervention of the lumbar spine takes the spinous processes out, okay? But on the lateral, in this case, there shouldn't be any spinous processes at these particular levels,
Right.
okay? And this should make you very, very happy. So the orthopedists, the spine surgeons say fusion generates conflict, okay? These abnormal forces lead to degenerative processes documented and may result in additional surgery, okay? So a non-physiological hinge effect or neo-hinge effect, what are they saying? If you fuse one part of the spine, you can expect to have other issues at other portions. That's where you come in as the chiropractic physician. Just because they had surgery doesn't mean they're gonna have won't have back problems elsewhere, caudate to the intervention, all right? And you'll learn next semester when we talk about bone pathology, not every surgical intervention has a successful outcome. They can get infection, and if they don't get infection, they can have post-surgical fibrosis, scar tissue, all right? So we get into that whole idea, but this should make you feel very, very good. If the surgeons are saying it, okay, we can certainly take advantage of this, in my humble opinion, okay? That's why you will have good luck with chiropractic intervention with these patients, all right? So by the time they get to semester 9, they say refer to orthopedic surgeon. In other words, they want to refer everybody, okay? So I'm trying to get ahead of that curve and say, there are certain questions you can answer in your office. Do I need oblique views? Do I need another intervention? Do I need to get previous records? Okay, but this should help. Just because they have surgery doesn't mean you can't work with them. But your documentation should say, in this case, sacrum 5-4, so 4-5 motor unit, I will not manipulate. It says on big red letters, okay? I'm working above, so no one can accuse me of that fact, okay? Damn. What is damn?
They messed up their sacrum, so they had to go in and,
The sacrum is normal.
is it?
Yes, it is. Keep looking.
Calcification somewhere.
Como?
They have an IUD, good. Okay, and I got
How did you know that's an
a
IUD?
lesson about IUDs this morning, okay? In, bone pathology class.
Oh, I should have done here. Still worth it.
That's, yeah.
Is that a herm?
That looks like a
vertebra?
zipper.
I'll give you this. Coccyx, sacrum and coccyx are normal. Keep looking.
Spina bifida,
Spina bifida, what level, please?
L5.
No, 5 is fine. 4, 3, 2. Is there radiolucency there?
Yep,
Yes, is there radiolucency there?
yep.
Okay, teaching point is complete your search pattern, okay?
So what's wrong with
I didn't even
L5?
have that part of the image on my
Yeah.
screen, I hadn't scrolled up.
Why does L5 look compressed?
Yeah, why does it?
In what way?
It looks like the vertebral body, yeah.
Yeah, but you've got lordosis here, and if this is tipped a little bit within physiological range of motion, okay, it's doing this, okay? And the reason you can't see this as clearly is because what you'd be doing on the lumbar spine exam lateral.
Lift your hands up.
Arm.
Okay?
So that's the same person?
Okay. Was it positioned well?
No.
So that's spina bifida L1?
And
L2.
2.
What is
Okay.
that radiolucency that the IUD is?
Gas, fecal material,
Okay.
zipper, all artifacts. Okay? You won't make the mistake, you're gonna be artifact everybody, right?
I was looking at it visually.
I was.
I didn't.
Not in my office, maybe in your office. Teaching point, name of condition?
Also done.
Osodontoideum, good. What's the big deal about osodontoideum?
That's a fracture that you.
Fracture that didn't heal,
But.
good, okay? Head hit the steering wheel. So when the head hits the steering wheel, you want good AP upward mouth view, all the routine views, so we don't miss, or we don't let this happen. Okay, so osodontoideum is a missed fracture. It has now become chronic, all right? Now they're gonna try and, somebody's gonna try and say, or somebody could say, you missed the fracture. No, I didn't. This is old, because I've got smooth margins and I've got an enlarged anterior tubercle. And it's still not trauma class, I'm just telling you, this is how we use the information that we learned last semester, okay? Pelvis, where does the central ray go, just to make sure?
Up above the iliac crest. Or
Above the iliac crest, no,
at the iliac crest.
no. Radial trochanter
At
for
the
central
pelvis?
ray, the top of the light goes to the top of the
Oh.
iliac crest,
Okay.
okay? What is this? It's metal, okay? Where's the metal supposed to be?
Not there,
Not there, where's there supposed to be?
Lateral.
unless it's shrapnel.
It's a gonadal shield. What's the point of the gonadal shield? To protect
It's not
the
where it's
reproductive
supposed to
structures.
be.
Okay, so if you're gonna use gonadal shield, at least put it in the right place. We know with the pelvis exam doesn't need gonadal shielding, right?
That's right.
So which is worse, not to have the gonadal shielding or put it in the wrong place?
Both.
Yes, right? Put it in the wrong place, then you can see.
Okay, just to show you,
That
Your balls are so fried.
Sorry.
soft tissue calcification where there shouldn't be calcification. So which part of my anatomy, or this patient's anatomy?
The knee.
The
leg,
knee, which part of the knee?
Patella area.
This is patella. Where's the calcification that shouldn't be there?
Lateral to
And
the
the tibia.
tibia.
lateral to the
Fibula.
fibula, there it is. Okay, here it looks like it's part of the bone, right? Here it's. The
Is
soft
that
Like
tissue.
it's in the
Is that radiolucency on the tibia, just the patella and the,
Direct me.
on the tibia, on the lateral, lateral
Just medial
aspect?
to R, right?
Yeah, right there, that radiolucency right there? No. The bone where, yeah, right there.
Well, you're not seeing the complete outline of the
Is that the
patella.
patella?
Yeah, that's all
Okay.
patella. Okay, but again, same thing, if you make it bigger on your device, there's a little spur coming off the inferior aspect. Okay, that's how they start. So if you have abnormal patellar mechanics, this is what can happen. Yeah, if it's tracking horribly, all right, this is not the examination, that's a clinical evaluation, but there's sensitive instruments where we can track, follow tracking, but on the x-ray, all we're saying is there's the spur formation, probably secondary to the abnormal tracking, and if it keeps abnormally tracking, this is going to get larger and larger and larger, and it affects the infrapatellar tendon. Okay, so the first thing is to say this is a bone tumor. No, recognize that that's why you want the AP view, soft tissue changes. Okay, in the old days we call it myositis ossificans. Okay, MO. These days we call it heterotopic HBO, heterotopic bony ossification. Okay, now we haven't done knee positioning, we will. Okay, it's an easy examination to do, so we're going to obviously we start hip, then knee, then foot, and ankle and foot. All right, so an example of calcification where there shouldn't be calcification. How old?
64.
64. What did I else did I write? Discomfort. That's it. I can't see from that angle. Okay.
APO mouth.
What's normal variant here?
It's age and spinal
Spinal
bifida
bifida.
occulta.
Okay, tough to see. It's easy to see on the cartoon diagram, but it can be small, medium, or large. I'll show you examples where this much of it is missing. Okay, 3 cases I've collected where this much of the posterior neural arch is missing, and the red is normal. Okay, in the one case he ended up playing high school or some kind of football. You don't want to let somebody who doesn't have a posterior neural arch play football. Okay, red is normal. When it's your turn, so this would be gone to the urgent care center, negative report comes back, the parents assume that that's factual, that's accurate. Okay, now they bring it to you because my son has suboccipital headaches. But yeah, if he's getting in playing football, practicing football, and hyperextending with trauma, okay, he doesn't have the posterior neural arch that everybody else does, so he's an at-risk patient. Okay, these little blips are just what I just said, little blips. Okay. Normal, not normal. So sometimes you'll be asked to x-ray a person who has a cast on because they've had previous trauma. Okay, how old? 47?
47. Horrible letters.
Thank you, 47. Why did the x-ray and put him in a cast?
Because
Make sure
of the,
everything's healing properly.
Okay, but before we assume that everything's healing properly, why do we put people in casts?
Fracture.
for
Fracture.
stability for fracture.
Where's the difference, the fracture? No, this is the abnormal, this is the normal.
It looks like the scaffold.
Scaphoid, okay, there's a normal one, this doesn't look the same, okay?
Mhm.
Smashed, all right, so the idea is you re-x-ray, you wanna see if this is progressing, as Haley, pointed out, okay? But you get a 4-week window, and if you re-x-ray in 4 weeks and this isn't doing anything, you can do ulnar deviation view, all right, and if it still looks funky, you wanna get an MRI, because we don't want this to progress to osteonecrosis, okay? By osteonecrosis, they'll try to get the 2 pieces opposed as closely as they can anatomically and put a screw in. If that doesn't work, you basically have a dysfunctional wrist, okay? How old? 47? He's got a good life ahead of him, so the idea is the sooner we make good clinical decisions, it's all about the progression. Your PA, oblique and lateral views didn't show anything, you know you can do ulnar deviation. If they still have anatomic snuff box pain after 2 weeks, it's time for an MRI. Don't mess with it, okay? Now we'll go into more detail on that, about that, and when we get to semester 8, But right now, that's how that information gets used. You know how to do a wrist examination. You know how to do a follow-up with the wrist examination. Back in the old day, we had to decide, okay, the cast adds some dimension to it. Now, just instead of saying this is a small body part in the digital world, you make it a medium one, and you'll get an x-ray that looks just as good as this. Okay?
It was osteo.
Necrosis, Necrosis, bone cell death. Okay, because the blood supply has been disrupted. Okay? Now, remember that osteoodontoideum we showed you earlier? Around the dens, there are blood vessels that are what big as a small thread. And when you hit the steering wheel, you never do straight on, you do a rotation, so complex movements. That tears those vessels, and that's how you get the dens fracture that doesn't heal properly. It's a problem with failure to revascularize properly. Okay. Now, where else do we have difficult challenges with revascularization? Clavicle. Why clavicle?
Is that because it forms a knot?
Yeah, it forms a knot, the bump, but why does a bump form?
Because of the type of ossification. that
Type
it
of
is.
ossification,
It's not
okay?
uncontrollable.
It's intramembranous. Okay, and intramembranous bones have less blood supply proportionally speaking. So if you have a clavicle that's fractured, it develops the knot because of that anatomic fact. Now, little people, they fall off their skateboards, they fall backwards, the forces come up, it's the clavicle that's commonly injured. Okay? So what did we say about shoulder x-rays, portrait or landscape?
Landscape.
That's why you want to see the entire extent of the clavicle. Now, the pattern is you'll get mid-clavicular fractures rather than sternal end or acromial end, but that doesn't matter. And if you can't see something, the patient persists in having pain, you can say to them, I'm going to shoot a clavicular spot view. Okay, and then you'll see the underside or the superior surface depending on what happened. Okay, back in, I don't know how popular skateboarding is these days. Yes, no? Back when my son was 8, it was the thing. Okay, so they're falling off their skateboards all the time. We come back to that when we do semester 8 trauma. Normal? Not normal.
Damn.
Ouchie, good, but the teaching point is, okay, entire length of the clavicle, all right, but your mid-thoracic spine has, when it has degenerative changes in it, that means something to you as someone who wants to manipulate that, okay? So, mid-thoracic segments, clavicle, lung parenchyma, all right, and in this case, this is not the normal, this is what the normal articular bed of the humerus is like, should be like. This one is dislocated, we'll come back to that, okay? Now, it doesn't take a fall on an outstretched hand. This lady fell on, she was curling. Now, I don't know whether she was sweeping the broom or whether she was stretched out pushing the rock. That's not a whole big lot of distance, like 6 feet from the top of the desk, okay, in this room. It's a small mechanism of injury. Long story short, she fell, dislocated. She went to her chiropractor. I don't know why she went to the chiropractor first. He took the x-rays, sent the x-rays and her to the emergency room. It took the better part of 2 hours to reduce this. In a bigger center, they don't normally wait 2 hours. They give you medication, you're out, and then it reduces easily, okay? But as it does that, all right, it disrupts the ligaments, the capsular ligaments, to the point where there is ulnar nerve or mass effect on the ulnar nerve. That's sort of how it all unfolded. We don't need to talk about that now, but okay, we will in trauma class. So it's all about your correct position. This is what we want. This is less ideal because we did lift up the uninvolved side. All right, and we teach you landscape orientation. How old?
6 or 7.
Case 6, 7-year-old
Oh.
female gymnast.
I was thinking the same thing.
Sorry.
I need to be more precise.
You
right?
should.
Okay, where's our abnormality?
In this L5S1 area?
Okay, L5, S1, what's the abnormality?
Anterior
Spondyly is
anterior
a conclusion. What's the radiographic finding?
Anterior spondylolisthesis.
Anterior listhesis, teaching point. you want to make sure you know whether there's a pars defect or not.
Yep.
Then we go into our routine, AP spot,
Yep.
okay? So if I'm convinced, I'm not convinced, so I'm gonna do an AP spot before I put my signature on that document, and I measure the translation, and the teaching point is to monitor further anterior translation. You're gonna do which view?
Oblique?
Lateral spot,
Oh, lateral spot.
okay, to monitor further anterior translation. So the first one is this, to see the pars. 6 or 7, if she keeps doing gymnastics, if this translates further anteriorly by Christmas time, that's important. Okay, so the teaching point is one's AP spot for pars area, lateral spot for further anterior translation. Okay?
Got it.
Yeah, that's why we say TP. Okay, she's how old? 7. She's going to have episodic lower back pain. And if this conservative care fails, they're gonna fuse her just like the first picture we saw. Posterior interpedicular surgical screws. Okay, let's say at age 15. No, when you finish college? 18, 19, 20? 19?
Depends.
Okay, she's finished her college career, now she says, I can't take the pain anymore, we fuse. Okay?
Yeah.
Well, even if they said, you can't, this is translated too far anteriorly, we have to fuse it, whenever that is. Okay, it's the same routine, that doesn't mean you can't treat her elsewhere, okay? And she will have episodic, the literature supports episodic back pain with these patients who have spondylolisthesis, and that can certainly be the case after they have surgical intervention. In other words, it doesn't go away. She's 7 now, if she's 37, she says, I can't take it anymore, they can't do more surgery, they've already surgically fixed L5, S1, okay? Something else. Okay? Chiropractic magic still works for her to an extent. Is it gonna be ever the same? No, it can't be because she's been surgically fused. That make sense? Yeah. I've shown you this before. How old? Rosie, how old?
5.
It says 5.
Am I sure? Okay, you know the mechanism of injury, x-rayed by the emergency department. For the last time, teaching point, don't assume that they do good work at the emergency department. There's abnormality. Where's the abnormality?
Same people.
There's radiolucency at the close plate.
So this is, we'll show you how to do a knee x-ray, but the point is, if the central ray should be at the tibial tuberosity, you'll put the central ray at the same point on your lateral examination.
Okay.
You can't see it on your lateral, because they
'Cause it's
didn't put the
not.
central ray. It's too high. This doesn't help, okay? Oops. This doesn't help,
What leg is it?
and there's that. Okay? So we don't know. What we say is in anatomic position, because the fibula is here, we're assuming it's the left leg, right? That's our supposition, because we accept anatomic position as a standard, okay? If they don't, if you can't tell, you're gonna have to call the office and say which limb was x-rayed. Okay? And then typical response is the person who took the x-rays, it's your day off today, so I will call back tomorrow. She says she got COVID, okay, now what? When can we start treatment?
You better do X-ray.
We've got the x-ray. We better ask the patient if we can, okay? But how would a 5-year-old remember? They should know, okay, which leg it was, but, okay, what I'm getting at is everything can fall through the cracks, right? Now we're COVID, we're 10 days out or a week out, week to 10 days before treatment is started, because what? Every x-ray, especially extremities, need to be marked,
Right.
okay? So one of these days, don't buy your favorite Starbucks treat for $10, buy yourself a set of x-ray markers. $6 to $10 for the set. If you think that's horrendously expensive, I'll buy you a set.
Oh.
You may need them in clinical practice.
When do I receive mine?
Where do you buy them?
There's a company in Fort Lauderdale called PB, capital P, lowercase b, markers.com.
And jelly.
Yeah.
PB and jelly.
pbmarkers.com, and they will even put your initials in so you know that you took the x-ray.
Let's look at that.
some fun ones, yes. So when you, at next opportunity, if you're shouting your doctors, ask them if they've had markers after they have the gonadal shields, okay? And if you really want to have a lunch given to you, say, I'm curious, do we take obliques? Yes. If we do a right anterior oblique of the lumbar spine, which pars do we see?
They're gonna be like,
Left. If I don't get left, they owe you lunch.
Oh, we should get lunch then. We're gonna all eat.
This is why they got wonderful DAC bars like you, sir.
Remember, I'm on the cruise, the perpetual cruise, around the world, cruise.
You still have your phone or your laptop with you?
Not in, the Alfalmi coast of Italy, they don't have reception there.
Well, they'll have Wi-Fi, you can get it, you're on the phone.
Okay, now the next thing, what did we say was the teaching point on trauma case?
Put it on the,
The ER doesn't do its job.
No, we said follow-up, right? 4 to 6 weeks later, this has to be re-x-rayed, make sure it heals well. That's your responsibility. The orthopedic surgeon says, I don't wanna mess with it, I've got another surgery to do. The chiropractic physician takes x-rays, he's capable of taking the follow-up films. Now, child or adult?
child.
Sir.
If you don't wanna deal with the little people, then don't mess with it and say, I'm sorry, I don't treat kids in my office, send them somewhere else. Okay, whoever is your pediatric chiropractor of choice. Does that make sense? Okay.
What's MLO stand for? No, it's on a marker. Not anywhere here.
Those are the
That's a whole
initials.
right side.
Yeah, oh, okay. Is initials or is it? Okay.
Initials, you can get your initials inscribed, or your significant other, or your worst enemy.
Oh.
Send them a set of markers with the wrong initials statement.
I want to put yours on there. Dr. Dombrowski, that's gonna be right there.
You're gonna pay a premium for that set of markers.
With the
So
Canadian
if you
flag
have
on it.
office with
The
a
Canadian
bunch
flag, I like.
So if you had an office with a bunch of people taking x-rays, you could get each person's label that you so you know who's doing it.
Okay, did everybody hear that?
No.
So you can get a multi, doctor office, multiple CAs taking x-rays, everyone will have their own set. So then we know if there's bad x-rays taken, it should be the marked ones, and then they have to go into remediation.
Fired.
I don't like that one. I'm kidding.
Okay? So we've solved this problem. All upper extremity views, right? Pediatric athlete, you all read the teaching points. That's fair game for this exam. I'm not asking you what you read about the wrist. I'm just saying there's 5 teaching points. There's the MCQs. I will certainly pay attention to what Angela's recording as far as teaching points go. Okay, 5 cases open like we usually do. Okay, guaranteed. I will use cases you haven't seen before. That's fair game. And open lab today, 4 to 5 if you're interested. If not, come next week. Okay, and we will the beat will continue. Yes, ma'am.
So you might have said this already, but I'm just curious. So if somebody comes in your office and they've got x-rays, they're hurt, right? Like you saw that knee person, they coming in, and we're reviewing the x-rays. I'm sort of answering my own question, I'm just thinking, like, when is a good idea to really just redo everything, you know what
Well,
I'm saying?
okay, I'll take a quick look at this. This is fine, but I can't use this. This has to be redone with more collimation, with markers, okay, because this isn't over. I have to do the follow-up films to make sure this is healing. If it doesn't heal, now it goes to an orthopedic surgeon, and he looks at my x-rays that are not good quality, and he says, damn chiropractors. I don't wanna say, I don't wanna hear that. I wanna see, these are the best x-rays I've seen from a chiropractic physician. I think I might refer my patient who has mechanical back pain to him or